And then finally in the crow's feet area, again, high dosing is very good here. I mean, you can go 10, 15 units per side, 30 units total easily with some extension treatments underneath the eye. And for most patients, I think that's really great. Now with Dysport dosage, very similar. Again, a 2.5 to 1 ratio just to keep it easy. We're using 20 to 22 units in the glabellar region, right at the club head of the brow, and another 5 or 10 units here. A total of 50 units is used in the glabella for our patients. Forehead, it's about 25, maybe 30 units in the forehead with some extension treatments. Again, these are evenly distributed aliquots of the product across the entire frontalis muscle. And for the orbicularis oculi, 25 to 30 units out here lateral to the orbital rim in the orbicularis will give a very good result that is long-lasting. Now, final comments on Botox. The FDA put out some guidelines and requirements for all of us as clinicians about safety labeling changes with the botulinum toxins. You've already heard the name. There's botulinum toxin A Botox. There's botulinum toxin A, which is Dysport. There's botulinum toxin B, which is Myoblock. So even the trade names or the generic names have changed as well as the trade names. There's a boxed warning about distant spread effects. This was generated as a result of some reports in kids with cervical dystonia that ended up having respiratory failure and dying. Obviously, we're not using those dosages. Obviously, our patients don't have cerebral palsy and respiratory or glottic insufficiency. And so I think it's a big stretch to give those warnings to our patients. But it does sort of remind us all that we must be aware that there are different products, there are safety issues here. And part of the FDA's release was this risk evaluation and mitigation strategy, or REMS, which had two primary elements. And the most important one in my mind is the communication plan, that every practice has a good plan to communicate what the side effects and benefits of these products are. There's also a medication guide that's been provided by the FDA, and the medication guide is a scary document because it suggests that all the cerebral palsy deaths can be tied to the patients who are treated for cosmetic applications. I really think that's over the top, but it's part of what we're required to do, and I think there are good ways of including it in your consent documents and or having those posted in the room. The most important part of that plan, the REMS mitigation plan, is communication with your patients. Again, side effects and risks are something that we're used to talking about with our patients, and it shouldn't be a big issue. I think the final words I'd say, which probably apply across all areas of aesthetic medicine, are the acronym STAY, where you set realistic expectations for patients. We make treatment assessments if necessary. We might want patients to come back the first time and make a follow-up appointment. And you, if that's the final of the acronym, the physician or staff are the reason that patients return. They don't return because of the product, they return because of the quality of their experience that they get. I would also remind everyone that there are some terms that we don't want to use when we're using the neuromodulators. Protein is a better word than toxin. Purified protein, not poison. Things like it smooths or relaxes. I like the term relax rather than freeze or paralyze. Freezing is a bad word now for people. They don't want to be frozen look. And then minimal discomfort, tiny injections, and temporary are all things that people enjoy. And the last thing I would remind everybody, because there's been a lot of concern about all these fly-by-night shops that are opening on every corner that are calling themselves Medi-Spas with nurse injectors who are not reporting to anybody with any experience, is that people really shop on quality, the quality of their treatment. These things will never be successful. They'll open, they'll close. They will never be successful because the quality is about the commitment of the physician, the provider, and the caregivers that are in that office. It's about their training, their oversight, and the quality of the delivery of the product that you give. It's not about Botox being easy or Dysport being easy to do. It's about the quality and consistency of delivery, the oversight and management of patients, and patients will return if you do a good job with these products. So I'd say in sort of final comments that the future is very exciting for us. We now have two botulinum toxin type A products that are available. We have Dysport and Botox. Both of them are good quality products. We have a lot to learn about Dysport. All we know is from the clinical trials. The clinical trials suggest that both of them are very similar. Dysport may start a little sooner in terms of its onset of action, and in some patients it may in fact last a little longer. But I think until we get a longer clinical follow-up outside of the glabellar area, it's going to be hard. It's far from making the conclusion that that's going to happen. I also think that going forward it would be very valuable to have more longitudinal controlled trials with botulinum toxin BOTOX Cosmetic, as their trials were truncated prior to really seeing a long-term follow-up. So post-marketing studies, head-to-head studies with Dysport and BOTOX would be very valuable studies for us. Going forward, we have the PureTox product, which may become available in the next 2 to 5 years. Very hard to say when it's in FDA trials, maybe even sooner. But I think that adding these products to our repertoire is a positive thing for patients or physicians actually that ask, well, we got a great product in BOTOX, why would you use something else? The answer is I'm not going to start using just something else. I'm going to use BOTOX. I'm going to add Dysport. It's another tool for patients. I'm certainly going to know how to use it. When PureTox comes around, I'm going to add it. I want to be familiar with all the tools that we have available to us and be able to offer them to our patients. So I think the future with these neuromodulators is exciting. We have 2 great products available to us now to treat our patients. Both are quality products. We may have more products on the horizon. Integrating them into our practice is a great opportunity for us to have some choices for both ourselves and our patients. I hope you found this educational program helpful. If you have any questions, don't hesitate to contact the American Academy of Facial Plastic and Reconstructive Surgery. Thank you.